Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Cyanide poisoning presents as a severe and rapidly progressing toxicological emergency characterized by nonspecific symptoms. Its tragic history dates back to its early isolation in 1782, and it has since been employed in warfare and caused numerous mass casualties. Exposure to cyanide can occur from various sources. Industrial exposure is common in metallurgy, mining, and jewelry production. Smoke inhalation from fires involving common materials can also lead to cyanide poisoning. Natural sources include cassava and apricots. Iatrogenic poisoning is possible with the use of nitroprusside, and intentional exposures can be facilitated by online instructions. Cyanide's toxicity arises from its disruption of cellular respiration. It inhibits mitochondrial cytochrome oxidase, which leads to cellular hypoxia, anaerobic metabolism, lactate buildup, and subsequent metabolic acidosis. Diagnosing cyanide poisoning is challenging, requiring a high degree of suspicion based on the context of exposure. Lab tests may indicate elevated lactate levels, acidosis, and increased venous oxygen saturation. The characteristic bitter almond odor is not a reliable diagnostic indicator. Rapid and empirical antidotal treatment is crucial for managing cyanide poisoning. This includes comprehensive supportive care and the administration of antidotes such as hydroxycobalamin or a combination of sodium nitrite and thiosulfate. Prompt recognition and intervention are vital to saving lives. Effective education on cyanide poisoning equips clinicians for prompt recognition and life-saving intervention in this critical toxicologic emergency. Mastering the following learning objectives is essential. Clinicians must recognize the diverse historical contexts and contemporary sources of cyanide exposure. These include industrial incidents, smoke inhalation, natural sources like cyanogenic glycosides in plants, iatrogenic causes such as nitroprusside, and intentional scenarios. Understanding the epidemiology is crucial for timely diagnosis due to the rapid and often nonspecific nature of acute toxicity. It is critical to describe the chemical forms of cyanide, including inorganic salts, hydrogen cyanide gas, and nitriles, along with their distinct toxicokinetic profiles. Hydrogen cyanide demonstrates rapid membrane permeability, and its primary detoxification pathway is enzymatic conversion to thiocyanate via rhodinase. Furthermore, clinicians should explain the fundamental pathophysiological mechanism of cyanide toxicity. This involves its high-affinity binding to the copper-iron binuclear center of cytochrome oxidase, which prevents cellular oxygen utilization. This leads to cellular hypoxia, impaired adenosine triphosphate ADP synthesis, and a severe anion gap metabolic acidosis. Identifying the varied and often nonspecific clinical manifestations of acute cyanide poisoning across organ systems is important. Emphasis should be placed on central nervous system symptoms such as headache, seizures, and coma, cardiovascular dysfunction, including initial tachycardia and hypertension followed by bradycardia and hypotension, and respiratory issues presenting as initial tachypnea followed by bradypnea and apnea. differentiating the typical onset of symptoms for direct cyanide exposures, which occur within seconds to minutes versus the delayed hours to days and prolonged toxicity associated with cyanogens like nitriles, which require metabolism to liberate hydrogen cyanide, is also vital. Clinicians must outline the key historical and clinical clues that should raise a high index of suspicion for cyanide poisoning. Examples include a fire victim with unexplained coma or acidemia, or the sudden collapse of an industrial worker. It is critical to acknowledge the unreliability of the bitter almond odor and the practical limitations of rapid definitive laboratory confirmation. Interpreting initial laboratory findings suggestive of cyanide toxicity, such as an increased anion gap metabolic acidosis, elevated lactate concentration, and elevated venous oxygen saturation, is necessary. Clinicians must understand that these findings are nonspecific, and definitive cyanide levels are often not available acutely to guide initial treatment. Prioritizing immediate, empirical antidotal therapy in suspected cyanide poisoning is crucial. This should be concurrent with aggressive supportive care, including meticulous airway management, ventilatory support, 100% oxygen administration, and management of hypotension and acidosis with crystalloids, vasopressors, and sodium bicarbonate. Finally, clinicians need to differentiate the mechanisms of action, dosing advantages, and key considerations for the primary antidotes, hydroxycobalamin, preferred due to lack of methemoglobinemia induction, and the sodium nitrite/sodium thiosulfate combination. They must select the appropriate agent based on clinical context, such as coexisting carbon monoxide poisoning or severe anemia. Discussion of other investigational or less commonly used treatments for cyanide poisoning, such as amyl nitrite for dimethylaminophenol, cobalt-tefallinodiamine tetracic acid, cobinamide, and dimethyl trisulfide DMTS, is also important to understand why they are not routinely employed as primary interventions in current clinical practice. Cyanide poisoning represents a critical toxicologic emergency with a rich and often tragic history and diverse epidemiology. Clinicians must understand its various sources and presentations for timely diagnosis and intervention, given the rapid and nonspecific nature of acute cyanide toxicity. Hydrogen cyanide was first isolated in 1782 by the Swedish chemist Carl Wilhelm Scheele, who reportedly died from its adverse health effects in 1786. This early recognition of its potent toxicity laid the groundwork for understanding its dangers. Cyanide was first employed in chemical warfare by Napoleon III and subsequently used on battlefields during World War I. During World War II, hydrocyanic acid pellets, notably under the brand name Zyklon B, were responsible for over 1 million deaths in Nazi gas chambers at sites like Auschwitz, Buchenwald, and Majdanek. Cyanide has also been used in mass suicides and criminal activity. In 1978, potassium cyanide was used in a mass suicide event led by Jim Jones of the People's Temple in Guyana, leading to 913 fatalities. Other notorious suicide cases involving cyanide include Wallace Carothers, Hermann Göring, Heinrich Himmler, and Ramon Sampedro. In 1982, 7 deaths in Chicago resulted from the consumption of cyanide-tainted acetaminophen, which subsequently mandated tamper-resistant pharmaceutical packaging. Numerous copycat murders followed, with a high-profile case in 2010 involving an Ohio emergency medicine physician who murdered his wife with a cyanide-laden calcium capsule. Cyanide is also used for illicit euthanasia. More recently, the deep or dark web has facilitated easier purchase of cyanide using virtual currencies like Bitcoin, making it more accessible. Cyanide exposure occurs in various environments, including industrial, accidental, natural, and intentional settings. Industrial and occupational exposures are significant. Cyanide is a chemical group consisting of a carbon atom triple bonded to a nitrogen atom. Inorganic cyanides, such as sodium cyanide and potassium cyanide, are utilized in industries like metallurgy, photographic developing, plastic manufacturing, fumigation, and mining. Sodium cyanide readily reacts with water to produce hydrogen cyanide gas. Occupations at risk include jewelry making, metal polishing, plating, stripping, reclaiming, and hardening, as well as nylon production, pesticide manufacturing and application, and laboratory work. Workers contaminated with powdered inorganic cyanide salts who wear wet clothing face a risk of dermal absorption of hydrogen cyanide. The American Association of Poison Control Centers National Poison Data System reported 1,258 cyanide exposures from 2011 to 2015. Cyanide exposure is also significantly linked to smoke inhalation, particularly from the combustion of materials such as wool, silk, synthetic rubber, and polyurethane. In the 2013 Kiss nightclub fire in southern Brazil, over 200 deaths were partially attributed to cyanide poisoning. The combustion of almost any organic compound containing carbon and nitrogen can generate hydrogen cyanide under appropriate conditions. Cyanide can be found in natural sources as cyanogenic glycosides. Many plants, including Manihot species, Linum species, Lotus species, Prunus species, Sorghum species, and Phaseola species, contain these compounds. The Prunus species, which includes apricots, bitter almond, cherry, and peaches, contain the glucoside amygdalin in their pitted fruits. When ingested, amygdalin is transformed by intestinal beta-D-glucosidase into glucose, benzaldehyde, and cyanide. Laetrile, which contains amygdalin, was inappropriately promoted for its supposed antineoplastic properties despite a lack of evidence. Ingested laetrile can cause cyanide poisoning, unlike intravenous infusion, which bypasses the necessary gastrointestinal enzymes to liberate cyanide. Cassava, Manihot esculenta, root is a vital food source in tropical regions and contains linamarin, a major cyanogenic glycoside. Proper processing is essential for safety, as inefficient processing leaves linamarin and cyanohydrin in the food, which can then hydrolyze to cyanide in the alkaline pH of the small intestines. Soaking peeled cassava in water for 5 days can lead to a 90% loss of cyanogens. Iatrogenic cyanide poisoning can occur during prolonged or high-dose nitroprusside therapy for hypertension management. Each nitroprusside molecule contains 5 cyanide molecules slowly released in vivo. If endogenous sulfate stores are depleted, as in malnourished or postoperative patients, cyanide can accumulate even at therapeutic infusion rates. Beyond historical mass incidents, current concerns regarding intentional poisoning include internet websites providing detailed instructions on how to produce hydrogen cyanide from various available chemicals. Cyanide poisoning is often considered a rare disorder by many physicians, which can lead to misdiagnosis. However, its potential for rapid and severe outcomes necessitates that clinicians recognize high-risk situations and environments where exposure may occur. A study of Poison Control Center data found that 8.3% of patients with intentional overdoses died, and 9% developed cardiac arrest. Notably, 74% of these patients did not receive an antidote, likely due to a failure to recognize the poisoning. Therefore, familiarity with the epidemiology and potential sources of cyanide is paramount for medical professionals. Cyanide presents in several critical forms, each with distinct properties and exposure risks. Inorganic cyanide salts, such as sodium cyanide and potassium cyanide, are common compounds. These are typically crystalline, white solids that are freely soluble in water. Hydrogen cyanide gas is a colorless and potent toxin. At a physiological pH of 7.4, hydrogen cyanide is a weak acid with a pK of 9.21, existing primarily in its undissociated form. Its low molecular weight, 27 Da, and non-ionized nature allow it to readily cross biological membranes, facilitating rapid absorption and distribution to target organs after inhalation. While historically associated with a bitter almond odor, it is crucial to note that most individuals describe the odor as pungent, musty, or metallic, and approximately 20% of the population cannot detect this odor at all. Furthermore, rapid olfactory fatigue can occur, leading to a false sense of dissipating danger. Organic compounds, specifically nitriles, contain a cyano group bonded to an alkyl residue. Acetonitrile and acrylonitrile are examples of such compounds. Although acetonitrile and acrylonitrile are not inherently toxic, they undergo biotransformation, primarily through CYP2 times 10 to the power of 1, to release cyanide within the body. Cyanogen gas, A dimer of cyanide reacts with water and breaks down into the cyanide anion. Cyanogen chloride is a colorless gas that is easily condensed and is classified as a chemical weapon agent. Clinicians must be acutely aware of the diverse chemical forms and varied sources of cyanide, the unique properties governing their absorption, and the potential for rapid or delayed toxicity highlight the urgency of early recognition and intervention in suspected cyanide poisoning cases. Cyanide poisoning presents a critical challenge in toxicology, demanding a thorough understanding of its pharmacology and toxicokinetics for effective clinical management. Cyanide itself is defined as a chemical group comprising one carbon atom triple bonded to one nitrogen atom. The dose of cyanide required to produce toxicity varies based on its form, duration, and route of exposure. However, even small exposures can be life-threatening due to its extreme potency. For instance, an adult oral lethal dose of potassium cyanide is approximately 200 milligrams. An airborne concentration of 270 parts per million or micrograms per milliliter of hydrogen cyanide is immediately fatal. Furthermore, exposures greater than 110 parts per million for more than 30 minutes are generally considered life-threatening. The Occupational Safety and Health Administration permissible exposure limit for hydrogen cyanide and cyanogen is 10 parts per million as an 8-hour time-weighted average concentration, with an immediately dangerous to life or health value for hydrogen cyanide at 50 parts per million. A lethal oral dose of hydrogen cyanide in solution is estimated at 50 milligrams in an adult. Acute toxicity can occur through inhalation, ingestion, dermal, and parenteral routes. Hydrogen cyanide readily crosses membranes due to its low molecular weight, 27 Daltons, and non-ionized state. After absorption and dissolution in blood, an equilibrium exists between the cyanide, anion, and undissociated hydrogen cyanide. At a physiologic pH of 7.4, hydrogen cyanide primarily exists as hydrogen cyanide. Rapid diffusion across alveolar membranes, followed by direct distribution to target organs, accounts for the rapid lethality associated with hydrogen cyanide inhalation. Understanding how cyanide is absorbed, distributed, metabolized, and eliminated is crucial for predicting its effects and guiding interventions. Regarding absorption, hydrogen cyanide is extremely well absorbed by inhalation, which can lead to rapid collapse and death within minutes at high concentrations. Significant absorption can also occur through the skin if high enough concentrations are present, especially with prolonged contact or abraded or burned skin. The dermal absorption rate increases as the pH of a cyanide solution decreases, as more HCN is formed. Most cyanide salts are rapidly absorbed from mucous membranes after ingestion, converting to HCN upon contact with water. Symptoms can occur within minutes, and death may occur rapidly. However, if cyanide salts are placed in capsules, symptom onset may be delayed for several minutes or longer. Concerning distribution, at physiological pH, virtually all cyanide in the body exists as HCN, which distributes widely after absorption. Measurable concentrations are found in the liver, spleen, kidney, brain, heart, spinal cord, lung, and fetus after acute poisoning. Cyanide is concentrated within erythrocytes by binding to methemoglobin. This binding can make red blood cell cyanide concentrations many times higher than plasma concentrations. The apparent volume of distribution varies depending on circulating methemoglobin concentrations and saturation of binding. The volume of distribution of the cyanide anion in humans is reported at 0.075 L/kg. Cyanide metabolism and detoxification primarily occur through its enzymatic conversion to thiocyanate. This conversion is essentially irreversible, and thiocyanate has relatively little inherent toxicity, being subsequently eliminated in urine. The main enzyme catalyzing this reaction is rhodinase, which is widely distributed throughout the body with the highest concentration found in the liver. Rhodinase transfers a sulfane sulfur from a donor, such as thiosulfate, to cyanide. Beta-mercaptopyruvate, cyanide sulfur transferase, also contributes to this reaction. In acute poisoning, the availability of adequate quantities of sulfur donors becomes the limiting factor in cyanide detoxification by rotainese. Endogenous sulfur stores are rapidly depleted, which in turn slows metabolism. This mechanism explains the effectiveness of sodium thiosulfate as an antidote, as it normalizes the metabolic inactivation of cyanide. Other pathways account for less than 15% of total cyanide elimination. These minor pathways include conversion to 2-aminothiazolene-4-carboxylic acid acetate, incorporation into the 1-carbon-metabolic pool, or combination with hydroxycobalamin to form cyanocobalamin. ACTA is notable as a reliable biomarker due to its long-term stability in biological material. Limited human data exist regarding the elimination half-life of cyanide, with reported values varying widely from 1.2 to 66 hours. This disparity is attributed to the number of samples used for calculations and the effects of antidotal treatment. Elimination follows first-order kinetics. When sodium thiosulfate was administered, the elimination half-life decreased significantly to approximately 10 minutes. The pharmacologic and toxicokinetic profile of cyanide underscores its rapid and potent cellular toxicity, primarily through the inhibition of cytochrome oxidase. Understanding the various sources, the rapid absorption, broad distribution, and the sulfur-dependent detoxification pathways is crucial for prompt and effective management of cyanide poisoning, especially given the nonspecific nature of its clinical presentation and the challenges of rapid laboratory confirmation. Cyanide poisoning is a critical toxicologic emergency due to its profound impact on cellular respiration. A thorough understanding of its pathophysiology is essential for prompt and effective clinical intervention. Cyanide is a chemical group comprising a carbon atom triple bonded to a nitrogen atom. Its toxicity stems from its ability to disrupt fundamental cellular processes. Cyanide inhibits more than 40 enzymes in the body. The most clinically significant mechanism of toxicity involves its high affinity for cytochrome oxidase, an iron-containing metalloenzyme located in the mitochondrial inner membrane. Cytochrome oxidase is crucial for oxidative phosphorylation, the process that transfers electrons onto oxygen to produce water and generate adenosine triphosphate ADP, the primary energy currency of the cell. When cyanide binds to the copper-iron binuclear center of cytochrome oxidase, specifically the cytochrome A3 portion, it prevents electron transport within the mitochondrial electron transport chain. This inhibition leads to a cessation of oxidative phosphorylation and oxygen consumption at the cellular level. Consequently, despite adequate oxygen supply to the tissues, the cells cannot utilize it, resulting in a state of cellular hypoxia. Cyanide disrupts aerobic energy production, forcing cells to shift to anaerobic metabolism. This shift rapidly increases lactate concentration and leads to metabolic acidosis. While elevated lactate levels are a prominent finding, the acidosis is not primarily caused by lactic acid accumulation. Instead, it arises because the normal buffering effect of adenosine triphosphate ADP synthesis, which consumes protons, is impaired. Cells continue to hydrolyze preformed ADP and anaerobically produced ADP from glycolysis. This hydrolysis generates protons that are no longer consumed by mitochondrial oxidative phosphorylation, leading to a net accumulation of hydrogen ions and consequent acidemia. Beyond its primary effect on cytochrome oxidase, cyanide also exhibits other cellular toxicities. It may inhibit glutamate decarboxylase, potentially decreasing brain gamma-aminobutyric acid GABA concentrations, which could contribute to seizures. Cyanide enhances N-methyl diaspartate NMDA receptor activity and directly activates the NMDA receptor, increasing glutamate release and inhibiting voltage-dependent magnesium blockade. This stimulation leads to an influx of calcium ions, Ca2+, into neuronal cytosols, activating voltage-sensitive calcium channels and mobilizing intracellular Ca2+ stores. The rise in cytosolic calcium ions activates biochemical reactions that generate reactive oxygen species, ROS, and nitrous oxide. These reactive oxygen species initiate peroxidation of cellular lipids, further impairing mitochondrial function and leading to cytochrome C release, triggering apoptosis and necrosis. The cellular metabolic derangement caused by cyanide also decreases the efficacy of endogenous detoxification enzymes, as reduced ADP, increased reactive oxygen species, and elevated cytosolic calcium ions stimulate protein kinase C activity, which inactivates rhodinase. Cyanide poisoning can manifest acutely or chronically, with varying signs and symptoms depending on the extent and duration of exposure. The onset and severity of acute cyanide poisoning are influenced by the dose, duration, and route of exposure, as well as the individual's premorbid condition. A critical combination of these factors can overwhelm the body's endogenous detoxification pathways, leading to widespread cellular dysfunction. It is crucial to note that no single reliable pathognomonic symptom or toxic syndrome is associated with acute cyanide poisoning, making the correct diagnosis challenging. Initial clinical effects are nonspecific, generalized, and non-diagnostic. Rapid collapse into coma or convulsions is a hallmark in serious cases, especially with high concentrations of hydrogen cyanide gas inhalation or intravenous injection of a water-soluble cyanide salt, with symptoms appearing within seconds. For ingested inorganic cyanide, symptoms may appear within several minutes. If cyanide salts are ingested in capsules, the onset of symptoms may be delayed for several minutes or longer, as they are prevented from immediate contact with oral mucosa. Delayed onset of symptoms for many hours can occur with exposure to nitriles, a type of cyanogen, as metabolism is required to release hydrogen cyanide. This delayed toxicity can also be prolonged, lasting for hours to days. For instance, acetonitrile exposure can lead to symptoms developing 15 to 20 hours later. Cyanide toxicity predominantly impacts organs sensitive to oxygen, particularly the central nervous system and cardiovascular system, resulting in rapid dysfunction. In the central nervous system, symptoms mirror progressive hypoxia. These include headache, anxiety, agitation, confusion, and lethargy, followed by non-reactive dilated pupils, seizures, and coma. Cyanide acts as a potent neurotoxin, showing a strong affinity for metabolically active brain regions. Survivors frequently exhibit brain injury in oxygen-sensitive areas such as the basal ganglia, cerebellum, and sensorimotor cortex, as observed on imaging. Cardiovascular responses to cyanide are complex. Initially, an increased heart rate and high blood pressure are common. This is subsequently followed by low blood pressure, accompanied by a compensatory increase in heart rate. The final stage consistently involves a slow heart rate and extremely low blood pressure. Electrocardiogram changes may encompass sinus arrest, irregular sinus rhythms, and progressive shortening of the ST segment, occasionally presenting with a T-on-R phenomenon. Ventricular dysrhythmias are uncommon. Regarding the respiratory system, effects include an initial centrally mediated rapid breathing, which is then followed by slow breathing and ultimately cessation of breathing. Post-mortem examinations have reported pulmonary edema. Inhaled hydrogen cyanide can also cause mild corrosive injury to the respiratory tract. Gastrointestinal symptoms such as abdominal pain, nausea, and vomiting can occur after ingesting inorganic cyanide and cyanogens. These symptoms are due to hemorrhagic gastritis, which is often identified during an autopsy. This condition is caused by the corrosive nature of cyanide salts. However, if death occurs rapidly, this gastritis may not be observed. A cherry red skin color has been described, resulting from increased venous hemoglobin oxygen saturation due to decreased oxygen utilization at the tissue level. Arterialization of retinal veins may be evident upon fundoscopic examination. Despite the inference in the name, cyanide itself does not directly cause cyanosis. However, the occurrence of cyanosis is commonly reported, likely caused by cardiovascular collapse and subsequent poor perfusion. The absence of bright red skin or blood should never be used to exclude the possibility of cyanide poisoning. Other common signs include diaphoresis and weakness. Serious cyanide poisoning is accompanied by a metabolic acidosis and a decrease in oxygen consumption. An anion gap metabolic acidosis is consistently present in serious cyanide poisoning unless the patient had a pre-existing serious metabolic alkalosis or received a significant amount of sodium bicarbonate. Arterial lactate concentrations are elevated due to the accelerated glycolytic conversion of glucose to lactate, which becomes an important source of adenosine triphosphate when oxidative phosphorylation is impaired. Additionally, elevated venous oxygen saturation, such as above 90% from superior vena cava or pulmonary artery blood, results from reduced tissue oxygen extraction, indicating decreased oxygen utilization. A small arterial venous oxygen difference is also suggestive. Hypothermia is a common finding in many patients with serious cyanide poisoning. Survivors of serious acute poisoning may develop delayed neurologic sequelae. Parkinsonian symptoms are the most common and typically develop over weeks to months. These symptoms include dystonia, dysarthria, rigidity, and bradykinesia. Subtle findings can appear within a few days. Head computed tomography and magnetic resonance imaging consistently reveal basal ganglia damage, specifically in the globus pallidus, putamen, and hippocampus. Radiologic changes typically appear several weeks after the onset of symptoms. Chronic exposure to cyanide can lead to insidious syndromes affecting both the neurological and endocrine systems, as well as various organs. One such neurologic syndrome is tobacco amblyopia, characterized by a progressive loss of visual function. This condition is observed almost exclusively in men who smoke, suggesting a reduced ability to detoxify cyanide. Another neurological manifestation is konzo, associated with the consumption of inadequately processed cyanogenic or bitter cassava. This can lead to neurologic issues such as spastic paraparesis, which is often sudden and symmetrical, affecting the legs more than the arms. Malnutrition, particularly low vitamin B12 intake, increases the risk of developing konzo. Labor hereditary optic neuropathy, a condition of subacute visual failure affecting men, is thought to be caused by mitochondrial DNA mutations that are exacerbated by exposure to cyanogenic glycosides. Chronic cyanide exposure is also linked to endocrine and organ effects. Thyroid disorders, including goiters and the development of hypothyroidism, are associated with chronic cyanide exposure. This is because thiocyanate competitively inhibits iodide entry into the thyroid gland. In animals, chronic cyanide exposure has been linked to hydropic degeneration in hepatocytes and epithelial cells of the renal proximal tubules. However, these morphological lesions have not been connected to functional alterations in these organs. In urgent treatment scenarios, clinicians must depend on the patient's medical history and initial clinical observations to suspect cyanide poisoning and begin therapy promptly, as laboratory confirmation is often not available quickly enough. One common misconception is that cyanide poisoning is easily identified by the smell of bitter almonds. However, most individuals do not notice this odor. Instead, it is described as pungent, musty, or metallic. Additionally, about 20% of the population cannot detect any smell at all. The ability to smell cyanide can also diminish rapidly due to olfactory fatigue, meaning that even if the odor was initially perceived, it may no longer be detectable shortly afterward. Therefore, the absence of a bitter almond smell should never be used as an indication to rule out cyanide poisoning. Contextual suspicion of cyanide poisoning should be considered in various clinical scenarios. For example, it may be suspected in cases where a laboratory or industrial worker suddenly collapses, in fire victims experiencing coma or acidemia, or in suicides presenting with unexplained rapid coma or acidemia. Additionally, ingestion of products such as artificial nail remover or seeds and pits from pruna species like apricots, bitter almonds, cherries, or peaches should also raise suspicion. Regarding laboratory findings, while rapid initial treatment decisions cannot rely solely on definitive blood cyanide concentration results, certain suggestive indicators can be helpful. These include an increased anion gap metabolic acidosis, elevated lactate concentration, and increased venous oxygen saturation. It is important to note that whole blood cyanide concentrations may sometimes be falsely elevated, particularly in patients receiving sodium nitroprusside or treated with sodium thiosulfate. Furthermore, these concentrations can vary depending on storage conditions. Diagnosing cyanide poisoning is a significant clinical challenge because its acute clinical manifestations are nonspecific. Additionally, obtaining definitive laboratory confirmation often takes time, which can delay diagnosis. Therefore, clinicians must maintain a high level of suspicion based on the patient's exposure history and initial clinical findings to initiate timely and potentially life-saving antidotal therapy. Laboratory findings in cases of cyanide poisoning reflect severe metabolic disturbances, but are usually nonspecific and not immediately available for guiding initial treatment decisions. One consistent laboratory abnormality is the presence of increased anion gap metabolic acidosis, unless pre-existing metabolic alkalosis or administration of bicarbonate confounds it. Elevated lactate levels in arterial blood are also common. However, it is important to understand that lactate is not directly responsible for the acidosis. Instead, the acidosis results from the accumulation of hydrogen ions, which are no longer effectively buffered due to the inhibition of mitochondrial oxidative phosphorylation caused by cyanide. While hyperlactatemia is a nonspecific finding present in many critical illnesses, there is a significant association between blood cyanide levels and serum lactate concentrations. Additionally, there is an inverse relationship between the pH of arterial blood and cyanide concentration. Elevated venous oxygen saturation, such as above 90% measured from the superior vena cava or pulmonary artery, or a small difference in oxygen content between arterial and venous blood, suggests decreased oxygen utilization and reduced tissue extraction. However, these findings are not specific to cyanide poisoning and can also be observed in other conditions such as carbon monoxide poisoning, hydrogen sulfide poisoning, sodium azide poisoning, sepsis, or high-output cardiac states. Importantly, cyanide does not impair the oxygen-carrying capacity of hemoglobin, nor does it create a saturation gap in arterial blood. Whole blood co-oximetry in cases of lethal cyanide concentrations does not reveal a saturation gap. Cyanide poisoning can also produce nonspecific electrocardiographic changes. These may include various rhythm disturbances such as sinus tachycardia, slow dysrhythmias, atrial fibrillation, or ventricular tachycardia and fibrillation. Changes in the ST segment can also be observed, but these findings are not unique to cyanide toxicity. When measuring cyanide concentrations, whole blood cyanide determination confirms toxicity, but it is not available rapidly enough to guide initial treatment. Whole blood cyanide concentrations can also be falsely elevated if plasma thiocyanate levels are high, for example, in patients treated with sodium thiosulfate or those who have successfully metabolized cyanide. This elevation is due to in vitro conversion during analysis. Whole blood concentrations are approximately twice serum concentrations due to cyanide sequestration in red blood cells. Coma and respiratory depression are associated with whole blood concentrations greater than 2.5 micrograms per milliliter and death with concentrations above 3 micrograms per milliliter, although values depend on the timing of collection relative to exposure. Specimen handling is critical as freezing and thawing can cause falsely high readings. Plasma cyanide can be used for diagnosis, but accurate measurement is difficult due to lower levels and the volatility of hydrogen cyanide. Serum and urinary thiocyanate concentrations are of limited value in assessing acute poisoning due to a lack of correlation with symptoms, but they are useful for confirming exposure. Urinary thiocyanate can also serve as a marker of cyanide exposure depending on collection timing. 2-aminothiazylene 4-carboxylic acid has been identified as a reliable biomarker due to its long-term stability in biological material and lack of significant influence from putrefaction. For semi-quantitative assay, Cyantesmo test strips, which are colorimetric paper strips used by water treatment facilities, can rapidly and accurately detect cyanide concentrations greater than 1 microgram per milliliter in a semi-quantifiable manner, offering a potential tool for clinical practice. The toxicological Differential diagnosis for sudden collapse, convulsions, metabolic acidosis, and decreased oxygen consumption despite adequate oxygen delivery is extensive. These symptoms strongly suggest cyanide or sulfide poisoning. Other potential causes include asphyxiation from inert gases such as methane, nitrogen, or carbon dioxide. Poisoning by hydrogen sulfide and sulfide salts should also be considered. Additional toxic exposures that can present similarly include methanol, ethylene glycol, pentaborane, azide, arsine, stibine, phosphine, phenol, cresol, and methyl halides. Carbon monoxide poisoning and methemoglobinemia are also part of this differential, though it is important to note that cyanide itself does not cause a saturation gap. Finally, other conditions characterized by sudden convulsions, hypotension, hypoxemia, and metabolic acidosis, such as poisoning by isoniazid or strychnine, should be considered. Diagnosing cyanide poisoning relies on a rapid integration of historical context and clinical signs, especially in high-risk situations. This is due to the nonspecific nature of its symptoms and the practical difficulties of laboratory confirmation in acute settings. Administering antidotes promptly and correctly in suspected cyanide poisoning is essential for effective management. Cyanide's rapid onset and high lethality, especially from high concentration exposures, necessitate immediate empirical therapy based on clinical suspicion. Definitive laboratory confirmation is often too slow to guide initial treatment. The management of cyanide poisoning, a toxicological emergency, requires swift and decisive action. The most crucial steps involve recognizing high-risk situations and immediately initiating empirical therapy with 100% oxygen and a specific antidote. Clinical suspicion is the cornerstone for prompt antidote administration, as there is no reliable pathognomonic symptom or toxic syndrome associated with acute cyanide poisoning. The initial clinical effects are often nonspecific and non-diagnostic, making a correct diagnosis challenging. However, certain circumstances strongly warrant immediate consideration and treatment. These include the sudden collapse of a laboratory or industrial worker and a fire victim presenting with coma or acidemia, particularly after the combustion of materials like wool, silk, synthetic rubber, and polyurethane. Other indicators are a suicide attempt with unexplained rapid coma or acidemia, ingestion of artificial nail remover, which historically contained acetonitrile or seeds or pits from pruna species such as apricots, bitter almond, cherry, and peaches. Additionally, a patient exhibiting altered mental status, acidemia, and tachyphylaxis to nitroprusside suggests iatrogenic poisoning. Before or simultaneously with antidote administration, meticulous attention to supportive care is vital. This includes controlling the airway, ensuring ventilatory support, and administering 100% oxygen. Hydrogen cyanide is extremely well absorbed by inhalation, and high concentrations can lead to rapid collapse and death within minutes. Rapidly obtaining intravenous access and sending blood samples for kidney function, glucose, and electrolyte determinations is also crucial. A whole blood cyanide concentration should be collected for later confirmation of exposure, although its results will not be available in time to guide initial treatment decisions. Crystalloids and vasopressors should be utilized for hypotension. Sodium bicarbonate should be administered and titrated according to arterial blood gas and serum bicarbonate levels to address the often severe anion gap metabolic acidosis. This acidosis primarily results from the accumulation of protons due to impaired oxidative phosphorylation, not solely from lactate accumulation. Decontamination should be performed concurrently with initial resuscitation. The primary goal is to protect healthcare providers from potential dermal contamination by using personal protective equipment. For inhalation exposure to hydrogen cyanide gas, it is critical to remove the patient from the contaminated area to fresh air. Further decontamination is generally unnecessary in these cases. For skin exposure to solid cyanide salts or solutions, all clothing must be carefully removed, any powder brushed off, and the skin thoroughly flushed with water. Special attention should be given to open wounds, as cyanide is readily absorbed through abraded skin. Inadequate decontamination can lead to continued off-gassing of hydrogen cyanide or delayed absorption. For ingestion of cyanide salts, while the effectiveness of activated charcoal is debated due to its low binding capacity, it is still recommended for patients with an intact, protected airway due to potential benefits and minimal risks. Gastric lavage is generally not recommended. Mouth-to-mouth ventilation for ingested cases is discouraged due to potential hydrogen cyanide gas regurgitation. In the United States, 2 primary antidotal strategies are available for immediate administration in suspected cyanide poisoning: hydroxycobalamin and the combination of sodium nitrite and sodium thiosulfate. Hydroxycobalamin is the preferred antidote. Its mechanism of action involves hydroxycobalamin, also known as vitamin B12A, functioning as a metalloprotein with a central cobalt atom. This atom directly complexes with cyanide to form cyanocobalamin, or vitamin B12, which is then excreted in the urine or bile. 1 molecule of hydroxycobalamin binds 1 molecule of cyanide with a molecular weight binding ratio of 50:1. This mechanism contrasts with nitrite-based antidotes by not inducing methemoglobinemia. For adults, the United States Food and Drug Administration approved adult starting dose is 5 grams intravenously infused over 15 minutes. A second dose of 5 grams can be repeated if necessary, depending on the severity of poisoning and clinical response, for a total dose of 10 grams. For pediatric patients, the dose is 70 milligrams per kilogram up to 5 grams to be repeated if necessary. Hydroxycobalamin offers several advantages. It has few adverse effects and does not induce methemoglobinemia, which is beneficial for patients with carbon monoxide poisoning or severe anemia where oxygen delivery should not be further impaired. Additionally, it may cause a mild, transient increase in blood pressure, which can be desirable in hypotensive patients with cyanide poisoning. However, there are also considerations and side effects. Hydroxycobalamin can cause a temporary reddish discoloration of the skin, mucous membranes, and urine. This discoloration may interfere with various chemistry laboratory analyses, such as those for aspartate aminotransferase, bilirubin, creatine kinase, iron, and magnesium, making accurate measurements difficult. It can also impede accurate measurements of carboxyhemoglobin, methemoglobin, and oxyhemoglobin by co-oximetry, which is particularly important for victims of smoke inhalation. Regarding evidence, while no randomized controlled human trials exist, uncontrolled and unblind case series have reported survival benefits. The best available data for its use currently constitute Level 3 evidence. The combination of sodium nitrite and sodium thiosulfate, previously known as the cyanide antidote kit, includes 2 components that work synergistically. Sodium nitrite acts as a methemoglobin inducer. Its mechanism of action involves nitrite oxidizing ferrous iron Fe2+ in hemoglobin to ferric iron Fe3+, which forms methemoglobin. Cyanide has a higher affinity for methemoglobin Fe3+ than for cytochrome oxidase, which is the primary target of cyanide toxicity. This creates a circulating sink of ferric iron that binds cyanide, allowing cyanide to dissociate from cytochrome oxidase in tissues and redistribute into red blood cells, thereby restoring mitochondrial function. Nitrite may also exert antidotal effects through improved hepatic blood flow and nitric oxide formation. For adults, the typical dosing is 10 milliliters of a 3% solution, 300 milligrams, intravenously over 2 to 4 minutes. In critically ill patients, it can be administered over 1 to 2 minutes, while in less severe cases, a slower infusion is preferred to mitigate hypotension. For pediatric patients weighing less than 25 kilograms, the dose is adjusted based on hemoglobin level, for example, 0.2 milliliters per kilogram of 3% sodium nitrite for an anemic child, refer to Table 123.2. If the hemoglobin level is unknown, presume 7 grams per deciliter for dosing. Regarding considerations and side effects, nitrites can lead to excessive methemoglobin formation and, due to potent vasodilation, may cause hypotension and tachycardia. Close monitoring of blood pressure is essential and rapid infusion should be avoided. Nitrites are generally withheld if carbon monoxide poisoning is suspected or if the patient has severe anemia, as both conditions can impair oxygen delivery, and methemoglobinemia would exacerbate this. Sodium thiosulfate, a sulfur donor, facilitates the detoxification of cyanide. Its mechanism of action involves providing sulfane-sulfur atoms that are essential for the enzyme rhodinase, thiosulfate cyanide sulfur transferase, to convert cyanide into the significantly less toxic thiocyanate. This sulfation is essentially irreversible, and the resulting thiocyanate is subsequently eliminated in the urine. In cases of acute poisoning, the availability of sulfur donors is the primary limiting factor for the body's natural detoxification process carried out by rhodinase. For adults, the recommended dosing is 50 milliliters of a 25% solution, 12.5 grams, intravenously over a period of 2 to 5 minutes. For pediatric patients, the dose is 1.65 milliliters per kilogram, up to a maximum of 50 milliliters of a 25% solution. A key advantage of sodium thiosulfate is its ability to enhance cyanide detoxification. When administered in combination with nitrites, it has been shown in animal models to significantly increase the lethal dose of cyanide more than either agent used alone. While thiosulfate itself is generally not associated with significant adverse reactions, thiocyanate, the product of detoxification, can potentially cause toxicity. This toxicity, which may manifest as abdominal pain, vomiting, rash, central nervous system dysfunction, or hypothyroidism, is more likely to occur in the presence of kidney failure or with chronically elevated concentrations of thiocyanate. Evidence suggests that both thiosulfate and nitrite individually possess antidotal efficacy in animal models, but they demonstrate greater benefit when used in combination. Similar to hydroxycobalamin, the strongest available data supporting this combination is considered level 3 evidence. When choosing between antidotes, hydroxycobalamin is generally preferred. This preference is especially strong in cases of smoke inhalation or in patients with severe anemia, where inducing methemoglobinemia with nitrites could compromise oxygen delivery. If a patient remains critically ill with metabolic acidosis despite maximal doses of one antidotal strategy, it is reasonable to administer the alternative strategy. For example, if 2 doses of nitrite/thiosulfate have been given and methemoglobin levels are high, adding hydroxycobalamin is logical. Conversely, if hydroxycobalamin has been administered and the patient remains symptomatic, the nitrite/thiosulfate combination can be given. Poisoning from cyanogens such as acetonitrile or acrylonitrile differs from direct cyanide exposure because these compounds are metabolized slowly to release hydrogen cyanide. The onset of symptoms may be delayed for many hours, typically between 3 to 24 hours after exposure. This delay occurs because a sufficient amount of hydrogen cyanide needs to be liberated through biotransformation. Therefore, patients exposed to potentially toxic doses of nitriles should be observed closely for 24 hours in a monitored setting with cyanide antidotes readily available, even if they are initially asymptomatic. Due to the continuous metabolism of nitriles, cyanide poisoning may persist for hours to days, necessitating prolonged antidotal therapy. If symptoms develop, treatment with sodium nitrite and sodium thiosulfate or hydroxycobalamin should be initiated as in acute poisoning. For prolonged toxicity, a continuous infusion of sodium thiosulfate, for example 1.2 grams per hour for 24 hours, is recommended to enhance cyanide transulfuration as it is produced. Repeated doses of sodium nitrite to maintain methemoglobin fractions or repeated doses of hydroxycobalamin may also be necessary, though exact schedules are not well defined. Investigational and other treatments for cyanide poisoning extend beyond the primary antidotes. Various agents have been explored for their potential role in management. Historically, amyl nitrite was included in cyanide antidote kits for pre-hospital use. It was delivered via crushed glass pearls to induce methemoglobin formation, but it has been found to be relatively ineffective compared to intravenous sodium nitrite. Its use has largely been discontinued in the United States, though it may still be used pre-hospital in some other countries. Another agent is 4-dimethylaminophenol, which induces methemoglobin more rapidly than sodium nitrite, with peak concentrations observed 5 minutes after administration compared to 30 minutes for sodium nitrite. It is administered at a dose of 3 milligrams per kilogram and is given alongside thiosulfate. Like sodium nitrite, its primary adverse effects include excessive methemoglobinemia and the potential for hypotension, which limit its use. Cobalt EDTA, used in some countries, acts as a cyanide chelator that undergoes renal elimination. It is administered intravenously, usually with a dose of 300 milligrams over 1 minute, with repeat doses if needed. However, its use is limited due to significant adverse effects, including severe allergic reactions, high blood pressure, rapid heartbeat, and swelling beneath the skin. Cobinamide, an investigational water-soluble analog of hydroxycobalamin, is being explored as a potential alternative antidote. It may not require intravenous administration, which would be advantageous in pre-hospital settings. Cobinamide is considered more potent than hydroxycobalamin because it contains 2 cyanide binding sites, allowing it to neutralize twice as many moles of cyanide per mole. Experimental studies in animals show that intravenous cobinamide is as effective as hydroxycobalamin at 1/5 the dose in restoring spontaneous breathing following acute cyanide poisoning. It has also shown promise as a novel therapy for hydrogen sulfide poisoning. Dimethyl trisulfide is a compound that acts as a sulfur donor for the enzyme rhodinase. It has demonstrated efficacy against cyanide poisoning in animal models and is being considered for pre-hospital use in humans. Beta-mercaptopyruvate precursors, including those administered orally, have shown effectiveness as cyanide antidotes in animal studies. They work by accelerating the conversion of cyanide into thiocyanate through the enzyme beta-mercaptopyruvate sulfur-transferase. However, none of these agents are currently available for human use. Disulfiram has been proposed by some authorities to inhibit the enzyme cytochrome P452 times 10 to the power of 1, which is responsible for converting acetonitrile into cyanide. This could potentially prevent the formation of significant amounts of cyanide, but there is insufficient data to recommend this therapy at present. For specific cyanide compounds such as acrylonitrile, studies suggest that an infusion of N-acetylcysteine may promote metabolism through pathways that do not release cyanide, similar to its use in acetaminophen overdose. However, no controlled human studies have confirmed this benefit. Hyperbaric oxygen therapy, which involves breathing pure oxygen in a pressurized chamber, is generally beneficial in hydrogen sulfide poisoning. While it was previously considered for cyanide poisoning, recent evidence suggests it offers no benefit in this context. Therefore, prompt supportive care with high-flow oxygen remains the primary treatment unless hyperbaric oxygen is immediately available. Animal studies have shown that antioxidant vitamins such as vitamins A, C, and E can reduce tissue damage caused by subacute cyanide intoxication. This is particularly relevant in regions where cyanogenic crops like cassava are dietary staples. However, these vitamins have not been proven effective in acute cyanide poisoning and are not recommended for this purpose. Although research continues into additional antidotes, the immediate and effective use of available therapies, combined with meticulous supportive care, remains essential in managing cyanide poisoning. Clinicians need to maintain a high degree of suspicion and act swiftly given the potentially life-threatening nature of this toxicological emergency. Cyanide poisoning is a critical toxicological emergency that requires comprehensive understanding by medical professionals due to its rapid onset, severe outcomes, and often nonspecific clinical presentation. Prompt recognition and life-saving intervention depend on mastery of key points related to its history, sources, chemistry, toxicokinetics, pathophysiology, clinical features, diagnosis, and treatment. Historically, cyanide has a long and tragic background, first isolated in 1782 and used extensively in chemical warfare during the World Wars. Today, exposure sources are diverse, including industrial and occupational settings such as metallurgy, mining, jewelry making, and plastic manufacturing, where inorganic cyanide salts like sodium cyanide and potassium cyanide are common. Smoke inhalation from burning materials such as wool, silk, synthetic rubber, and polyurethane is also a significant cause. Natural sources include plants like cassava and prunus species, including apricots and bitter almonds, which contain cyanogenic compounds. Ingestion of products like Laetrile containing amygdalin can also lead to poisoning. Iatrogenic causes stem from prolonged or high-dose nitroprusside therapy, while intentional exposures have increased with online access to cyanide production instructions, along with historical mass suicides and criminal activities. Understanding these sources is crucial because cyanide poisoning is often considered rare, leading to potential misdiagnosis. The high mortality rate among patients with intentional overdoses highlights the importance of recognition, as many succumb or develop cardiac arrest without receiving antidotal treatment. Cyanide exists in various forms, including inorganic salts, highly volatile hydrogen cyanide gas, and organic nitriles. Hydrogen cyanide is a colorless gas that remains undissociated at physiological pH, which allows it to cross biological membranes easily due to its low molecular weight and non-ionized state. Absorption occurs rapidly through inhalation, ingestion, and contact with abraded skin, leading to widespread distribution throughout the organs. Even small exposures can be life-threatening, with lethal doses estimated at around 200 milligrams for adults when ingested and immediate fatalities at hydrogen cyanide concentrations of approximately 270 parts per million. Detoxification primarily occurs via enzymatic conversion to thiocyanate by the enzyme rhodinase, which requires sulfur donors like thiosulfate. In acute poisoning cases, sulfur stores are depleted rapidly, impairing detoxification and increasing toxicity. The resulting thiocyanate is eliminated through the urine. The pathophysiological mechanism of cyanide toxicity involves its high affinity binding to the copper iron centers within mitochondrial cytochrome oxidase. This binding inhibits cellular respiration and halts electron transport, leading to a condition called cellular hypoxia, despite adequate oxygen supply. Consequently, tissues shift to anaerobic metabolism, causing a rapid rise in lactic acid and creating severe metabolic acidosis with an increased anion gap. Cellular damage is further exacerbated by inhibition of enzymes such as glutamate decarboxylase, increased activity of NMDA receptors, and production of reactive oxygen species, all contributing to cellular apoptosis. Clinically, cyanide poisoning presents with nonspecific symptoms that can be challenging to diagnose. Serious cases may lead to rapid collapse into coma or seizures within seconds to minutes, especially with inhalation or intravenous exposure to hydrogen cyanide or ingestion of inorganic cyanide salts. Sometimes, symptoms appear hours later due to the need for metabolic conversion of nitriles to hydrogen cyanide. Common signs involve dysfunction of organs sensitive to oxygen deprivation, including the central nervous system, which manifests as headache, anxiety, seizures, and coma, and the cardiovascular system, initially showing tachycardia and hypertension, then progressing to bradycardia and hypotension. Respiratory symptoms may include initial rapid breathing, followed by slow or stopped breathing. A characteristic feature sometimes noted is a cherry red skin color because of increased venous oxygen saturation, although cyanosis can occur due to shock and absence of skin discoloration does not exclude poisoning. Laboratory findings often reveal an increased anion gap metabolic acidosis, elevated lactate levels, and increased venous oxygen saturation, reflecting impaired tissue oxygen extraction. However, rapid measurement of blood cyanide concentration is typically unavailable and not useful for immediate clinical decisions. The distinctive odor of bitter almonds is rarely perceived, as most individuals cannot detect it, and it should never be relied upon to diagnose cyanide poisoning. Diagnosis requires a high index of suspicion, integrating clinical presentation with exposure history. Sudden collapse in industrial workers or laboratory personnel, victims of fires with unexplained coma or acidemia, and suicides involving ingestion of seeds or pits of certain fruits should raise concern. The variability in symptom onset depends on the form and route of exposure. Immediate empirical treatment is essential and should often be initiated before laboratory confirmation. Supportive care includes ensuring airway patency, providing ventilatory support with 100% oxygen, establishing intravenous access, administering fluids or vasopressors for hypotension, and correcting acidosis with sodium bicarbonate. Decontamination procedures include removing patients from contaminated environments, thorough skin flushing for dermal exposure, and administering activated charcoal if ingestion has occurred and the airway is protected. Antidotal therapy involves the use of agents like hydroxycobalamin, which directly bind cyanide to form cyanocobalamin, a harmless compound excreted in urine. This antidote is preferred because it has few side effects, does not cause dangerous methemoglobinemia, and can raise blood pressure slightly. Dosing typically involves rapid intravenous infusion of 5 grams over 15 minutes for adults, with repetition as needed, and weight-based dosing for children. The combination of sodium nitrite and sodium thiosulfate is also used, especially in settings where hydroxycobalamin is unavailable. Sodium nitrite induces the formation of methemoglobin, which has a higher affinity for cyanide, acting as a circulating sink, although it can cause hypotension and excessive methemoglobinemia, so caution is advised if carbon monoxide poisoning or anemia coexists. Sodium thiosulfate supplies sulfur to support enzymatic conversion of cyanide to thiocyanate, which is less toxic and excreted via the kidneys. Adult doses are typically 300 milligrams of sodium nitrite administered intravenously over a few minutes and 12.5 grams of sodium thiosulfate given over several minutes. In some cases, especially with nitral toxicity, patients may require prolonged observation and ongoing antidotal therapy, such as continuous sodium thiosulfate infusion, due to the delayed and extended toxicity profile. Other treatments for cyanide poisoning include some investigational or less commonly used options. Amyl nitrite, which was once more widely used, has largely been abandoned. For dimethylaminophenol is another treatment that acts as a methemoglobin inducer, but is not considered a primary option. Cobalt-tethylene-diamine tetrachic acid has been studied, but its use is limited due to significant adverse effects. Cobinamide is an investigational drug that is considered potent and shows promise for future treatment. Additionally, sulfur donors such as dimethyl trisulfide are being explored. Hyperbaric oxygen therapy has been evaluated but has not demonstrated any benefit in the treatment of cyanide poisoning.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.